Welcome back to the Mama Podcast, brought to you by Mama Academy, the safer pregnancy charity. In this episode, we're talking about plus-size pregnancy, cutting through stigma, fear-based messaging and assumptions, and focusing instead on evidence, personalised care and informed choice. Heidi is joined by Alice Keely, a midwife with around 25 years experience and a specialist plus-size midwife for more than 15 of those years. Alice has completed a PhD in plus-size pregnancy, works as a senior university lecturer, and has spent much of her career researching and improving care for patients who are too often labelled as high risk from the outset. Together they explore what plus-size pregnancy actually means in clinical terms, what care and recommendations parents might encounter, and why being plus-size is not a complication in itself. Alice shares clear, reassuring insight into risk versus reality, common interventions, navigating conversations with healthcare professionals, and how parents can advocate for care that is individual, evidence-based, and respectful. If you're pregnant, planning a pregnancy, or supporting someone who is, this episode is about confidence, clarity, and putting choice back where it belongs, with the parent.
Welcome to this episode of the Mama Podcast. I'm Heidi Eldridge, the founder and CEO of Mama Academy, and I'm here with Alice. Alice, please introduce yourself to our listeners. We'd love to find out all about you.
Oh, thank you so much for inviting me on, Heidi. I'm delighted to be here. I'm Alice Keely. I'm a midwife and I work as the Heavyweight Midwife. I've been a midwife for about 25 years, actually. A long time now, and a specialist plus size midwife for about 15 of those years. I completed a PhD in plus size pregnancy after working in a specialist clinic. So it's really been my focus for, as I say, about the last 15 years. I'm from Yorkshire. I've worked as a midwife in London, Scotland, and now back in my native Yorkshire, and I'm also a university senior lecturer, teaching midwives and undertaking research as well. And I live with my 3 kids and my dog. And when I'm not doing midwifing stuff, I'm out walking in the Yorkshire Hills with the family. That's my favourite thing to do.
Oh, how lovely! How lovely! That just sounds absolutely idyllic, especially today when the actual sun shines out.
We do have some sunshine here today. Yeah.
So,
sunshiny day.
I guess my question is, what is the definition of a plus size pregnancy, and how did you get into being a specialist in plus size pregnancies?
Yeah. Oh, well. So plus size pregnancy is kind of my term for, there are words that can be more difficult and more offensive to people, like obesity. So that's a clinical word, and that tends to be what health professionals use. And those are kind of clinical categories, but they also sort of mean things in the social world, don't they? They kind of stigmatise people. So I always use plus size pregnancy, and so I guess for me, anyone who's plus size, it's kind of a sort of a self-categorising thing. So anybody that is worried themselves about either their weight and their health, or how they might be treated by health professionals during their pregnancy care as a result of their weight. They can access me and they can access my reassurance. If you are planning a pregnancy or you're pregnant, then plus size pregnancy is kind of defined by clinical categories, which is dictated by body mass index measurements and a much more kind of clinical definition. So there are things that will be recommended to you, interventions, tests, medications, restrictions, based on categories of BMI from the categories that you might be familiar with. So BMI 19 to 25, 25 to 30, 30 plus, 40 plus. And that's so clinically there are guidelines around those sorts of things. So that's where the relevance is. And the reason that I became interested is that I guess I've always been, my family background really broadly, my family are quite a political family, so I was always sort of brought up with a background of kind of social justice and fairness and challenging discrimination. And when I became a midwife, I worked when I was quite newly qualified in a team where we looked after women with very complex medical and pregnancy needs, and we kind of championed the sort of midwifery, the kind of maintaining the unique sort of family and social nature of pregnancy, and trying to add the midwifery as well as the kind of medicalised to that. So then I had the opportunity to work with a university as well as my NHS trust, and Tommy's the Baby charity, there was a role for a midwife setting up a clinic for women who are plus size to have their antenatal care, but also to take part in research studies. So I became involved in clinical research, and I ran this antenatal clinic for women with a BMI above 40. And at that time, I became really interested in their experiences, really, and whether a sort of specialist clinic for them was the best way to do the care. So I got that job, and then I just became very interested in how we might do things better in terms of the care that they got. So that's how I came to be involved and specialising in plus size care. So that was about, oh no, actually more like 20 years ago. Time's going by. That was around about 2006, 2007. Yeah. We're nearly 2026 now, aren't we? Goodness.
I know. Where have the years gone? Well, that's really interesting. So what could a plus size woman expect then in terms of care? Because you said the care might be different.
Yeah, well, there are various different things according to, as I say, these BMI cut-offs that might be recommended or should be recommended according to the guidelines. What's kind of key, and I suppose what I really always want to emphasise, is that there might be messaging that if you're sort of thinking of pregnancy and thinking about getting pregnant before you actually do it, you might very early on start to get this idea in this message that plus size pregnancy is high risk. And my kind of main mission, I suppose, is to kind of reframe that. But perhaps we can just come back to that. But what you might get overall is this idea that there are increased risks, and that there are different things that are recommended to you. And what's useful to know is that, what's not always told you, you might get recommendations given to you, but you might not always kind of have the detailed discussion around what's sort of strongly recommended, what is a really sort of significant risk, or what is the nature of the risk, how high is the risk, and what do we know about it. And that's what's problematic with this kind of, this pregnancy is high risk, that people might say to you, and therefore we recommend X, Y, and Z. That said, if at the beginning of your pregnancy, your midwife is going to want to calculate your BMI, and that's done by weighing you, usually, calculating from your height and your weight, get this BMI number, and then you'll be recommended, if your BMI is above 30, that is the clinical category of obesity, maternal obesity. And then, therefore, you'd be recommended to have a glucose tolerance test, a test for gestational diabetes, when you're towards the end of your second trimester. And you may also be recommended to, if your BMI is a little bit higher, you might be recommended to take aspirin during pregnancy. You might be recommended to take blood thinners during pregnancy. You might be recommended to see an obstetrician rather than having just all of your care with a midwife. You might be recommended to have additional scans, growth scans, later on during your third trimester of pregnancy. And you might be recommended, and this is where all those things are kind of a little controversial and should be kind of discussed in detail. And you might be recommended to have an induction of labour for various different reasons. And the thing to note there is that lots of women that might be mentioned to them very early on, and that's really not probably what they're thinking that they do want. So there's a kind of often a sort of a depersonalized approach, because obviously when you're maybe 16 weeks, so lots of people see consultants at around 16 weeks or 20 weeks to see a consultant obstetrician. And at that point, it might be that induction is mentioned already, just based on the kind of just in case. And that sort of starts to undermine people's confidence a little bit. It's not at all individualized. So it's not based on kind of what's happening with you at the end of your pregnancy and what might be safe for you. It's just, we're just going to generalize about the fact that you're bigger, so you might need help. So those are things that might be recommended that you have, but in addition to that, you also might be recommended not to have your care with a midwife in a midwife-led unit, or to have a home birth, or to have a water birth. And you also might be recommended to have an epidural early on during your labour, because you might see an anaesthetist. You might be recommended to see an anaesthetist, and so that might all be recommended to you. So this kind of interventions and things that are a little bit kind of frightening might be recommended to you at various points during your pregnancy. So there's quite a lot. There's quite a lot that I talk to women all the time about. We spend time. I spend time talking about the evidence and kind of reassuring women about their choices and the questions to ask, and how to get things in perspective in terms of how in terms of health and pregnancy, and how not high risk their pregnancy actually is.
Okay, and what actually are the risks? I know you mentioned gestational diabetes. That's obviously something that they might be of higher risk of getting gestational diabetes. But what else would be the risk of having a plus size pregnancy? What would you need to look out for?
Yeah, so there are if you're plus size, what researchers do is they look at whole populations of people, and they look at kind of trends and averages. And the reason that I mention that is that if you're sitting in a waiting room and you're plus size, and you're sitting next to somebody who's not plus size, and you're both in the antenatal clinic, nobody can actually say to you that you'll have complications and that other person won't, or how much more likely you might be. And that kind of high risk label is really kind of it can be slapped onto people quite early, and it's not kind of based. It can't be individualized to people. That said, it's across the population of pregnant women, there is a greater likelihood that you might develop a number of different pregnancy complications. One being diabetes, as you mentioned, gestational diabetes, and another being preeclampsia. Now, so it is more likely that you might develop some complications based on averages, such as gestational diabetes or preeclampsia. And I think that gestational diabetes is something that lots of women will know about and be conscious of. And we do know that if you are bigger, that is more likely to happen. But I think, and actually this happens with health professionals as well, people get a very, very overblown idea, I think, because of the high risk label. I think that, to me, if you describe somebody as high risk in pregnancy or in whatever situation, that sounds like it's likely to happen, doesn't it? To me, it does anyway. It's a high risk thing. So I think people they get a sense of, and also because the stakes are high when you're pregnant, you're worried, they really get a sense that this is a big risk, it's a high risk. Whereas women, gestational diabetes is caused by pregnancy, as the name would suggest. And it's very complex. It's too complex to kind of go into now, but it's sort of based on it's because you have a placenta growing. If you are plus size, you've got around about a 10 to 20% chance in your pregnancy of developing gestational diabetes, compared with a chance of around about 4 to 7% if you're not plus size. So clearly, based on averages, the risks, the chances are higher. But they're still low compared to the chances of not developing gestational diabetes. So that's always because I know that people have this constant messaging around, from social media, health professionals too, from their family, maybe worrying about them. They get this sense that their pregnancy is high risk, and almost inevitability of complications, or the expectation of it. So that's where my ethos kind of comes from. Is yes, there are higher chances, but all of the chances of all of the complications of pregnancy are low. In fact, that elevation with gestational diabetes is the biggest kind of elevation of a complication happening, of any of the complications of pregnancy that can happen. Unfortunately, what also can happen, it's very, very, it's by no means everybody within healthcare, but you can, very much have risks focused on all the time. You can have choices restricted, and you can have, as I say, sometimes you can have, if you dream of having a water birth, for example, as lots of my clients do, then you can have those choices restricted, unless you kind of know how to navigate the system well. So, and also there are lots of interventions suggested, such as epidural induction, that aren't that affect your experience and outcome. So that those are also kind of chances of things happening. That we know that plus size women are more likely to have cesarean sections, for example, and that is not. It can't be shown to be simply because of their size. It's because of because more of them are recommended to have inductions for reasons that aren't necessarily individualized or very evidence-based. Having an epidural early also increases the chance of having other interventions like cesarean. So it's a really complex picture. And also if they are restricted from midwife-led birth and water birth, then that also then increases the chance that you might have a cesarean section if you're restricted there as well. So it's really important to kind of know about how to be well holistically. So, how to have a healthy pregnancy, but also how to navigate and be ready for any health professional that talks to you about risk or tries to restrict your choices. Because what you need to know about is the evidence, and about how actually the most likely journey for you is that you won't have any complications, and to kind of focus on that, and then treat risk as dynamic. Pregnancy is a dynamic journey, and risks is dynamic. But my main message is, which is borne out by the evidence, if you get to the end of pregnancy and you don't have any complications on the day that you go into labour and have your baby, then really you should. There's no clinical reason why you should be treated differently to anybody else. I always say that being plus size might be a consideration for your care and for your pregnancy and birth, but it's not a complication in itself.
Yeah, absolutely. So we're always talking about empowerment and doing lots of research and learning about all the evidence so that you can make an informed choice that's right for you. And as you say, you could have complications, you could have preeclampsia, you could have gestational diabetes, you could have all sorts of different things going on, in which case, you discuss that with your clinician and your maternity team, and you work out the best thing for you with all the different options that you have. But you're right, if there's absolutely no complications whatsoever, and you're just being sort of refused certain things just simply because of your plus size, then we always, say you can get a second opinion, and you can empower yourself with lots of information. In fact, our website's got advocacy tools on it as well.
Yeah.
So that helps sort of navigate difficult conversations and helps partners be able to advocate on your behalf if you're unable to. That's all very helpful. So it is all about empowerment, isn't it? And just learning lots of different things.
It is. And I do. So sometimes I get a little bit frustrated with, because, well, that you spend a lot of time on social media, don't you? Because there's a lot to be learned. There's lots of people in the sort of birth world. And I sometimes get frustrated if people say, you can just refuse anything. You can just refuse anything that you don't want, or you don't feel happy with. But an example of that is I have a really big community, and a Facebook group alongside that. And there's a lot of talk in there often about the gestational diabetes test, so the glucose tolerance test, GTT. And my take is always that, because it's it can be a stigmatizing, getting that diagnosis is very hard. It's not just hard and stressful and emotional to manage having gestational diabetes for a lot of people. It feels like a guilt-laden, stigmatizing diagnosis for a lot of people. I always encourage people to think of it as, that is information that is really helpful for you. Now, the problem with diabetes is uncontrolled diabetes. If you have a diagnosis that you can then work with, and you can control your blood sugar, then that is, then uncontrolled diabetes is a problem. Well-controlled diabetes is like your body doesn't know you have diabetes, so it's really, really useful for you to have that information. I'm not somebody who, life's never that simple, is it? I'm not somebody who says you should do this or you shouldn't do that. You just need to have information, and like you say, have tools, ask the questions that gets you that information. The difficulty with some of the restrictions are that women often don't know what they're working with. So if we're thinking about birth itself, which is what the main focus for a lot of people, obviously there's a lot of decisions during pregnancy, but your mind is on that the day of your baby's birth and the unknowns around that. So lots of women I work with want to have water birth, and lots of women that I work with want to have an elective cesarean section, for various different their own unique reasons. Now, different hospitals have different guidelines around BMI and water birth, which isn't helpful because we have a lack of evidence. There are no national guidelines. So often women aren't they don't know what they're going into when they're going into that negotiation. And then with elective cesarean section, women that I work with, they experienced a range of advice, scaremongering, and pressure sometimes from consultants, ranging from you should have a cesarean section, you should have an elective cesarean section for whatever reason that consultant's saying, or you shouldn't have elective cesarean section. So trying to advocate and have a conversation about their choice and the various risks and benefits, because nothing is without risk or benefit. So that's where you should work if you're working in that kind of birth space. As you say, is helping people you can really tell somebody the right answer for their own choice, can you? Helping them to know a bit about the guidelines and how systems work, but how to build their confidence and ask those all important questions for them.
Yeah, that's really hard to navigate, isn't it? Because you put your trust in the healthcare professionals, in your obstetrician, in your midwife.
Unfortunately, the end of our conversation with Dr. Alice was corrupted. So we haven't been able to deliver our normal, high-quality, full-length episode. But Dr. Alice has some amazing resources available on her Instagram at the Heavyweight Midwife and on her website, theheavyweightmidwife.com. She also runs a fantastic community full of plus-size people who are currently pregnant or have gone through pregnancy. So please make sure to check that out. You've been listening to the Mama Podcast from Mama Academy. If you enjoyed listening to this episode, share it with a friend or colleague. Make sure you follow us so you don't miss out on our next episode. If you'd like to support our work by fundraising or volunteering, please email contact@mamaacademy.org.uk. For more information on pregnancy and maternity services, please visit our website at www.mamaacademy.org.uk. We're also on all of your favourite social media channels. See you next time!